So Chapter 23, Introduction to Hematopoietic Neoplasms, is the first section or chapter that discusses precancer and cancer states. It really provides just a general intro to these types of disorders and describes how oncogenesis and oncogenes are activated in their association to certain types of hematopoietic diseases. So we're going to classify these types of conditions or neoplasm according to their cell lineage, their degree of differentiation and morphology. You're going to be able to identify cytochemistry, immunophenotyping, and any kind of genetic abnormalities that could lead to the precancer and cancerous state. And then we'll just discuss some clinical and lab findings, as well as prognosis and treatment for these types of conditions. So a neoplasm in general terms is a tumor, or just means new growth. They arise from a kind of dysregulated proliferation of a single transformed cell. Genetic mutations in these cells reduce or eliminate the cell's dependence on those external cytokines needed in regular types of proliferation. So neoplasms are either malignant or benign. Benign are formed from highly organized types of differentiated cells and really do not spread to the surrounding tissues. In contrast, malignancy means deadly or having the potential to cause death, and a malignant neoplasm is a clone of abnormal proliferating cells which have the potential to metastasize or spread. Now really only malignant tumors are correctly referred to as cancer. Although cancer is actually a malignancy of epithelial tissue, the common use of the term includes malignant neoplasms. And these malignant neoplasms in hematology are referred to as leukemias. In hematology, we can consider diseases or disorders as a spectrum as things change. We've already discussed the benign changes that happen in hematology, and they can range anywhere from this green area to the red area, meaning the red area able to cause death. So usually in the green area we have benign types of changes, and they are, a reactive process most of the time. And then we get into certain types of mature and myeloid and lymphoid types of neoplasms. So we're getting into the yellow phase where these are pre-leukemic states. And then we get into neoplasms that are derived from mutated precursor that cannot stop producing, but has a very limited capacity to mature. Now, cells can't do their job if they don't mature, so this leads to an acute leukemia, and that is an uncontrolled proliferation, which blocks this maturity, and then we get genetic mutations that can result in death. So when we look at Table 23.1, we really need to compare the precursor and mature types of neoplasms. So if we talk about precursor or acute types of neoplasms versus mature types or chronic, we can definitely consider, first of all, the age of the patient. You're going to be getting case studies, so we should consider what happens most of the time. Okay, so usually in these acute types of phases, they can occur at different ages, while the mature types or chronic types occur later on in life. The onset for the acute, as its name, is quickly or sudden, whereas the mature or chronic takes many months to years to form as a course of untreated. If left untreated, it can be definitely deadly, especially for the acute types. So the predominant cell here is a blast. There may be some mature forms, but again, you're definitely going to be able to distinguish between acute and chronic types of neoplasms by the cells that are there. In the mature types, you're definitely going to see cells that are able to mature. And the anemias will be present now because it is affecting the bone marrow overall. So with the acutes, you'll see a mild to severe type of anemia, and in the mature types, you'll see a mild. Okay, similarly with thrombocytopenia, you're going to see that these are going to be variably affected and have a mild to severe type of thrombocytopenia and acute types of neoplasm, and mild decreases in mature or chronic. Now the white blood cells can vary, okay, in acute types of leukemia. Okay, this can vary from very low to very high types of white blood cell counts, where in the mature types, we are consistently seeing an increase in the total white cell count. Now here's an example or a slide from an acute type of myeloid leukemia. We are seeing a number of these myeloblasts that are in the peripheral smear. Okay, none of these cells should be seen outside of the bone marrow, and we have the majority of the cell being these acute large blasts that really can't differentiate into the cell they're going to be, and they can't do their job. So quite deadly case. Now in this cell, you see a pre-leukemic state, considered a chronic myelogenous leukemia. So you do see some immature forms, but you do see a lot of predominance of mature forms. So we can see this as a condition in that yellowish range of the spectrum of a precancerous condition. We will also discuss lymphomas. Okay, these are an abnormal proliferation of lymphoid cells in lymphatic tissue or lymph nodes. And the picture below is a cross-section of a lymph node tissue. So this is the only type of specimen we're going to talk as solid tumor, as majority of hematological cancers are discussed as leukemias, as in free-flowing blood from the bone marrow. As we saw in the spectrum, we kind of see a clonal expansion of these neoplastic cells. Remember, the expansion of a neoplasm has to start with one mutated cell, and then over time, the normal cell population decreases and the neoplastic cell population increases. And this usually happens in the bone marrow first, where you get an increase of those neoplastic cells that start to spill out into the peripheral blood. So on the right, we see the development of a normal hematopoietic cell, where it starts at the stem cell and commits to a progenitor cell line, and then matures into one of the 5 white blood cells that we have studied in the past. On the left-hand side, we have a mutation here, a leukemic mutation that results in a single cancer-initiating cell. So if this cell commits to a progenitor, then the mutations can also self-renew. Okay, so you have the blue arrows here indicating that. Now, if the mutation also results in a block in terminal differentiation, means in maturation all the way to the mature state, as seen in the right as this neutrophil, then they will result in an acute type of leukemia because none of the cells can mature. So when we talk about the molecular basis of cancer, we talk about the cancer cell genotype that is generally maintained or inherited during cell division. So this implies that the tumor cell DNA determines the disease phenotype. So when we're talking about oncogenes, okay, we find that tumor viruses can carry these discrete genetic elements, or oncogenes, that are responsible for inducing malignant cell transformations. So the proteins encoded on these play an important role in the cell cycle, such as initiation of DNA replication and any kind of transcription and control of the genes. So, importantly, a lot of viral oncogenes have normal counterparts in the human genome called proto-oncogenes. Now, these are verified from the human genome because it carries genes with potentially the ability to alter the cell growth and cause malignancy when it's altered or activated to an oncogene. That's like a turned-on process to initiate cell proliferation. But another property are called tumor suppressor genes, where tumor suppressor genes function to inhibit the cell growth in normal cells. Okay, so in addition to the oncogene activation that results in growth promotion, tumor cells often have an inactivating mutation of suppressing growth and can contribute to tumor development. So these are both ends of the spectrum. Now there is also another group of alterations called epigenetic alterations. Now, inherently, epigenetics is defined by the heritable changes in gene expression not caused by changes in DNA sequence. So these changes are stable from one cell generation to the next after each mitotic division. These changes play an important role in development and differentiation and are associated with silencing certain genes to become specific cells. If these are stable, you can also see epigenetic alterations that induces cancer proliferation due to modifications in DNA methylation patterns usually. So when looking at the cell cycle, we look at a common feature of cancer is the loss of regulation during these checkpoints, right? Each time a cell proliferates, it has these checkpoints that it goes through to ensure the cell can proceed through division. Either get the positive signal, signal by cytokines as positive regulators, but they also have to be regulated, so they have loss of function or negative regulators to make sure it doesn't go out of control. Now, when this fails, we normally see an uncontrolled proliferation of these mutated cells leading to cancer. So we know to keep balance within the body and homeostasis, cells need to proliferate, differentiate, and die. So during cancer states, you usually have an accumulation of an excess number of cells, which is very characteristic of malignancies, resulting in increased proliferation, but we also see a decrease in cell death or apoptosis. So the mutations of genes important in regulating this have also been identified as an oncogene and a tumor suppressor gene. What results is an increased production of cells, an extended lifespan, and a diminished cell death situation. When we talk about leukemogenesis, or the cause of creating a leukemic disease, we know that there are several factors that play a role. So first is genetic susceptibility. We have seen a number of individuals who have congenital abnormalities associated with a certain karyotypic abnormality have a dramatically increased risk of developing acute types of leukemia. For example, a Down syndrome patient in which they have an extra chromosome 21 has a 100-fold chance of getting an acute type of leukemia. Now, somatic mutations is another cause, and it's an acquired change in the genetic material of cells other than those involved in reproduction. So mutations in the chromosome near these proto-oncogenes are likely to play a role in the neoplastic development in these cases. And some of those causes can be from radiation, chemicals, and drugs that cause chromosome mutations. As for viral infections, Any retroviruses have been known to cause leukemia, and because they can have or contain a reverse transcriptase that allows them to produce a DNA copy of the viral RNA core, and it can be copied to produce more viral core DNA copies and mutate the cell. Now, in addition to karyotypic types of genetic susceptibility, we also have immunologic dysfunction that is an increased cause of leukemia as well. And these disorders include the hereditary immunological diseases that we talked about with lymphocytes, such as Wiskott-Aldrich or any type of X-linked agammaglobulinemia. There's also miscellaneous factors where any of these causes above don't fall into a specific category, but these genetic or other kinds of diseases appear a risk to causing cancer. Now, these can be those precancerous states or any kinds of neoplastic conditions that we will talk about and seen in the spectrum in that yellow zone above. Now, the age groups of acute versus chronic leukemias need to be addressed because you need to identify what cells are more common in which age groups. So if you're seeing children at the ages of 2 to 5 come in as a type of leukemia, you know that the majority of their cells are lymphocytes, so the majority of the cases seen in this age group are acute lymphocytic leukemia types. Now, adults of over 50 years old, you might start to see more chronic lymphocytic types of leukemia or mature types of leukemic cells. Now, adults ranging in many ages have been seen with acute or pre-leukemic states, and you will have to be able to identify these based on the patient ages. Failure of the normal triad of hematopoiesis is a most serious consequence during neoplasm development. So the most frequent symptoms are related to erythrocytopenia, thrombocytopenia, and or neutropenia. And the major clinical problems seen are anemia, infection, and bleeding episodes during hemorrhages, petechiae, or increases in bleeding through mucosal membranes. On physical examinations, patients may complain about bone pain because of the bone marrow expansion and also weight loss, as well as a palpable spleen or liver. When we talk about hematological findings, we will most likely see at first a normocytic, normochromic type of anemia. If not, the anemia invariably develops during the progression of the disease. The platelet counts also vary here, where thrombocytopenia is usually present when you have more acute types of cancers. And thrombocytosis is a common finding in some mature types of neoplasms, but can decrease with disease progression. And again, depending on the type of a leukemia and the age, you will have variable cell counts where it's either normal, decreased, or increased, but you will definitely have an increase of immature forms, and blasts are more prominent in the acute types of leukemias. Now, with leukemias in the bone marrow, it will usually have a hypercellular picture. On occasion, it will be normal cellular, but over time, you might start to see a hypercellular picture as patient starts to shut down. Blasts here are normally increased in the bone marrow, resulting in a minimum of 20% to have a diagnosis into the acute type of leukemia categories. Health Organization has based and classified the lineages of neoplastic cells into three major groups, either myeloid, lymphoid, or histiocytic and dendritic. We are going to focus mostly on the myeloid and lymphoid lineages. Now, why are we classifying these types of leukemias? Because first, they provide clinicians and researchers a way to study and compare various types of therapies. They also provide a system for diagnosis using clearly defined clinical features as well as lab features. And they permit meaningful associations of certain types of genetic abnormalities with pathogenesis of neoplastic disease. And each of those classifications are grouped as either precursor acute or mature chronic. Now, diagnosing and being able to classify a neoplasm starts with the CBC and the peripheral blood picture, which leads to a reflexive bone marrow aspiration and biopsy. Here you're going to get a morphology and a blast count. You're going to perform flow cytometry and differentiate into the cell lineages, as well as do cytogenetic analysis of the molecules or any kind of mutations identified. Now, prognosis, or the patient outcome based on these conditions, really relies on if the patient is able to go into remission. So if you're talking about hematological remission, you want an absence of any of those neoplastic cells in the peripheral blood and the bone marrow. So usually, after treatment, these will return to normal levels of hematological parameters. That way, you will have a hematological remission, which is a very favorable prognosis for these types of patients. Now, you also have cytogenetic remission. So if a genetic abnormality has been identified, you see an absence of those recognized cytogenetic abnormalities associated with the given neoplastic disease. So if that abnormality goes away after treatment, again, then this is very favorable prognosis for the patient. As for treatment, we have chemotherapy remains the treatment of choice for many types of leukemias because the goal of this type of therapy is to eradicate all malignant cells within the bone marrow and allows a repopulation of residual normal hematopoietic precursors. Now, the problem is it's not really specific for leukemic cells and kills many normal cells. That's why you lose your hair during chemotherapy. Now, they are coming up with monoclonal and specific gene-targeted therapy, so cancer treatment in the future is looking very promising.